OEH seminar. This is also our last seminar until September, so enjoy. This week we have the pleasure of having David Stieb giving us a talk. David Stieb is a public health physician with the Environmental Health Science and Research Bureau at Health Canada, where he has been working in the area of air pollution epidemiology since 1993. Areas of interest include application of epidemiology to analysis of the public health impacts of air pollution and systematic review and meta-analysis methods to environmental epidemiology. He was based in Ottawa until 2011, at which time he came to Vancouver in search of rain and a bigger mortgage, and now works out of the Vancouver Regional Office of Health Canada. So I'd like to welcome everybody here in person and our online audience to this talk.
All right. Well, thanks very much. And my dreams have come true with the rain and the bigger mortgage. Yeah, so thanks for having me, especially for the last session of the term. So I'm going to talk about health effects of air pollution in rural areas. And there are a couple of reasons why I chose this topic. First of all, there's a tendency in air pollution epidemiology to focus on urban areas, and notwithstanding the work that Sarah and Mike Brower and others have done looking at wood smoke and wildfire smoke in rural areas. Secondly, there may be sort of unmet air pollution risk communication and management needs in rural areas if these populations are unaware either of their susceptibility or exposure to air pollution. So it's going to take a sort of epidemiology 101 approach, looking at this in terms of population exposure and outcomes. First of all, in terms of population, what do we mean by rural areas? Characteristics of rural populations, in particular factors that mediate susceptibility to adverse effects of air pollution. And then on the exposure side, wanted to highlight some methodological innovations in the exposure science that have really transformed our ability to understand air pollution exposure in rural areas, and also contrasting some of the differences in exposures in these areas in summer and winter. And then finally, looking at health outcomes, I'll provide a few examples of studies that have exploited these innovations in the exposure science area. All right, so starting with population. Statistics Canada really defines rural areas by exclusion. So urban areas are those with a population of greater than or equal to 1,000 and a population density over 400 per square kilometer. And rural is basically everything else. There's a slight refinement to the terminology in 2011 that they now refer to population centers instead of urban areas, and divide them into small, medium, and large. So 1,000 up to less than 30,000, 30,000 to under 100,000, and 100,000 and over. And another sort of related concept is that of the metropolitan influence zone. So this pertains to the percent of the labor force in rural areas that commute to larger urban centers, CMAs being census metropolitan areas and CAs census agglomerations. And so the degree of influence ranges from none to strong, with the percent of the labor force commuting ranging from 0 to over 30%. Now, the percent of Canada's population living in rural areas has declined dramatically over the last 150 years. Back in the 1850s, about over 80% of the population lived in rural areas and less than 20% in urban areas, and those numbers have now essentially reversed. Over 80% of the population living in urban areas and less than 20% in rural areas. But it does vary considerably among the provinces. So you can see here on the left side of the screen, in the Atlantic provinces And on the right side of the screen, in the territories, 40% of the more of the population lives in rural areas, whereas in Ontario, Alberta, and BC, that proportion is less than the national average of 20%. Now, while the relative proportion living in rural areas has declined, the absolute population has obviously grown over the years and now is steady at about 6 million. So, substantial absolute population still living in rural areas. Looking at the age structure, this is the population pyramid comparing urban areas in the blue shaded area and the red line highlighting rural areas. So age along the vertical axis and proportion of the population essentially on the horizontal axis. And you can see with the lower arrows a smaller proportion of individuals 15 to 45 in rural areas, and a larger proportion age 50 and over in rural areas. So that's of interest in terms of susceptibility to air pollution effects. Then in terms of health status, this is from the 2001 Canadian Census Tax Mortality Cohort. So this is the successor to the CanCheck or Canadian Census Health and Environment Cohort that's been used to look at long-term effects of air pollution exposure. And so this is based on about 3.5 million people who completed the long-form census in 2001 and then were linked to the mortality database. And so this shows the age standardized mortality rate ratio for men and women by community size. And you can see there's an obvious gradient increase in the rate ratio moving from larger to smaller communities, both for men and women, but more pronounced for men. Now, there are other factors that mediate susceptibility to adverse effects of air pollution exposure, including time activity patterns, occupational activity, and housing characteristics. This paper was an earlier version of it was called Lifestyles of the Urban and Rural. So it's based on the Canadian Human Activity Pattern Survey, or CHAPS-2. CHAPS-1 was carried out in the mid-1990s. And so this study was done in the summer of 2010 and winter of 2011. About 3,500 urban respondents and 1,500 rural respondents. You can see the urban locations listed there. The rural locations are Haldeman, Norfolk, which is on the north shore of Lake Erie in southern Ontario. And the Annapolis Valley, Kings County, is in northwest Nova Scotia, bordering on the Bay of Fundy. So this study involved a 24-hour recall diary where respondents were asked to recall their activities in 15-minute increments for the previous day, and then a supplemental questionnaire that asked that collected additional data. So some of the findings, rural respondents spend more time outdoors. So this is minutes per day by age group. And in every age group, this was true, and it was significant in particular in the 5 to 11, 20 to 59, and 60 plus age groups. And the difference was sort of 40 to 75 minutes more outdoors per day in rural areas. Also, rural respondents were more likely to work outdoors, so almost 40% in rural areas compared to 23% in urban areas. As well, to work in strenuous outdoor occupations, 11.5% versus 4.4% in urban areas. And also to spend time near gas or diesel powered equipment, 17% versus about 5% in urban areas. And this was not sensitive to adjusting for age, sex, or socioeconomic status. They're also less likely to have air conditioning at home, so about 40% in rural areas and close to 60% in urban areas. And this is important because air conditioning is a known effect modifier for adverse effects of air pollution because it reduces penetration of outdoor pollutants indoors. So moving on to exposure, wanted to highlight, as I mentioned, a few of the innovations in exposure science that have really transformed our ability to characterize exposure in rural, also in urban areas. First of all, remote sensing using satellite observations to characterize exposure really at high spatial resolution, generally at limited temporal resolution, and with certain limitations. Next is chemical and meteorological models. So these use emissions data, weather data, and atmospheric chemistry to model exposures both at high spatial and temporal resolution. And then finally, land use regression, which uses saturation monitoring campaigns combined with land use data to model exposure at high spatial resolution, but again, generally low temporal resolution. And so all of these methods have been combined or fused with ground-based monitoring data to generate exposure surfaces with both high spatial and temporal resolution. Now, before these methods were developed and applied, air pollution exposure assessment was really restricted to areas in the vicinity of sparsely distributed ground-based air pollution monitoring. So this shows the really sparse distribution of the NAPS, or National Air Pollution Surveillance Program, sites across the country. But with these new methods, we now have these comprehensive exposure surfaces. So this shows a surface for ozone, which Mike Brower and others published and was used in the Global Burden of Disease assessment. So this is really a globally comprehensive surface, only with the exclusion of some areas in the extreme north and south. And similarly for PM 2.5, or fine particles. So these surfaces have been applied to assign exposure to a number of cohorts. So again, I mentioned the Canadian census tax mortality cohort. And so this has allowed investigators to map exposure to both urban and rural areas. And so you can see here that there's a clear gradient of increasing exposure to both PM 2.5 and NO2, moving from rural to urban areas. But in the case of ozone, there's a really very limited difference between rural and urban areas, and I'll say a little bit more about that in a few minutes. Now, one other thing that we've used these exposure surfaces for, and this is still sort of work in progress, is to look at variability of both susceptibility and exposure to ozone and fine PM around Canada. So what we did was start with a couple of critical reviews that were published by authors from the US EPA, looking at factors that mediate adverse effects of, or that modify the adverse effects related to PM and ozone. And this allowed us to identify a number of factors that could be quantified in the Canadian population. So we divided this into a restrictive set of criteria, which was children under 10 or adults 75 and over, people with asthma, COPD, heart disease, or diabetes, and pregnant women. And then a more inclusive set of criteria, which added older children, younger seniors, outdoor workers, those with inadequate vitamin C intake, and that's a measure of ability to, or defenses against oxidative stress, and then finally those with less than a high school education. And then we quantified those among 110 health regions across Canada using census data, Canadian Community Health Survey data, national fertility data, and published literature. So this shows the findings based on restrictive criteria, so divided by quartile, and you can see that the percent of the population deemed susceptible ranged from about 24% to 41%. There are a couple of areas in northern Saskatchewan and Quebec that were excluded from the CCHS. And then you can also see that the areas in red that had the highest percent susceptible population were mostly outside large urban centers. And then we overlaid ozone and PM 2.5 exposures based on these comprehensive surfaces to see where the highest quartiles of susceptibility and exposure overlapped. So these two inset figures show in southern Alberta the health region outlined in bold, and then the number of health regions in southern Ontario where that fell in the highest quartile of both percent of the population susceptible and exposed to either ozone or PM 2.5. Now, there are a couple of areas here that are not shaded red. They weren't in the highest quartile based on the restrictive criteria for susceptibility, but they were based on the more inclusive criteria. And again, all of these health regions are outside of large urban centers. Now, the lower Fraser Valley, it didn't quite make it into the highest quartile of ozone exposure based on the data that we used, but the BC Environment has characterized on their website the lower Fraser Valley as having one of the worst smog problems in Canada outside the Windsor to Quebec City corridor. So this just highlights a key sort of exposure issue in rural areas in the summer months is photochemical smog. And so this figure shows data for 2014 and the clear gradient in exposure moving from Vancouver out eastward into the Fraser Valley based on peak ozone exposures. Now, there are a number of reasons for this, why ozone exposures in some instances are actually higher outside of urban areas. And apologies to atmospheric chemists, it's a lot more complicated than this, but one of the reasons is that there's a lack of scavenging of ozone by NO in rural areas. So in urban areas, you have lots of NO being emitted by vehicles in particular. It combines with ozone under certain conditions and produces NO2 and oxygen. But there's relatively little NO emitted in rural areas, and so you don't have that scavenging occurring. Another issue is, or another set of factors is weather and topography. So again, this shows the lower Fraser Valley, and what this is illustrating is that you have onshore breezes that carry pollutants and their precursors from Vancouver eastward, and these get trapped under certain conditions by temperature inversions and also by the valley topography in rural areas. So this is also an issue in eastern Canada. So this is a map of coal-fired power plants across the U.S. And so you can see the concentration of these plants upwind of eastern Canada. And so these generate pollutants and pollutant precursors that get transported to eastern Canada. And from the sounds of it, this situation could get worse in the next few years rather than better. Now, another issue in rural areas in the summertime is wildfire smoke. So this is kind of a cumulative map of fires from 1980 to 2015, and these are the largest fires, over 200 hectares in perimeter. So it's a relatively small number of fires, but accounts for the most sort of damage, sort of like the income or wealth distribution. And basically no surprise that the locations of these fires mostly corresponds to where the fuel is or where the trees are. In other words, the location of the boreal forest. Then moving to the winter, wood smoke is a particular issue in rural areas, and this is a photograph from Mark Gibson at Dalhousie, showing a plume of wood smoke and being trapped during an inversion episode. And there's also some topography and evidence here in the Annapolis Valley. And it's been shown with source apportionment studies that wood smoke accounts for up to 70% of PM 2.5 emissions, particularly in the Atlantic provinces. So I've highlighted here New Brunswick, Nova Scotia, and PEI, where between 50 and 70% of PM 2.5 emissions are accounted for by wood smoke. And if you recall the figure I showed earlier showing the percent of population living in rural areas by province, and it actually fairly closely parallels the importance of wood smoke as a source of PM 2.5. Okay, so moving on to health outcomes. As I mentioned earlier, I wanted to highlight some of the studies that have used or applied these developments in exposure science to be able to include rural areas. But first of all, I wanted to sort of go back in time a little ways to a couple of studies that were done many years ago. And I think the sort of motivation at that time for some of these studies was to sort of exploit some of the either susceptibility or exposure factors that I'd mentioned in rural areas that would kind of maximize the signal that might be detected in an epi study. So this is a summer camp study that was done over 25 years ago in Connecticut, and this was one of a number of these camp studies that, in this case, involved children 7 to 13 attending an asthma camp. So this was in Connecticut, outside of large urban centers, and you can see that the ozone exposures during the study exceeded 150 parts per billion. And so the figure on the left shows the increase in reporting of respiratory symptoms in association with ozone, and on the right, the decrease in peak flow in association with ozone. So again, this was exploiting the fact that you have children exercising outdoors in a setting with high ozone. And then moving closer to home, again, this study was conducted nearly 25 years ago in the Fraser Valley, looking at a more highly exposed population of outdoor agricultural workers. And so this involved doing spirometry daily before and after the workday. And it's interesting that daily maximum ozone concentrations during the study went up to 84 parts per billion, which is almost identical to the values that I was showing earlier in the Fraser Valley based on 2014 data. And again, in this study, ozone was associated with decrements in lung function, FEV1 and FVC. Okay, so jumping back to the present, as I said, I wanted to highlight a few studies that have taken advantage of these developments in exposure science. So this is based on the agricultural health study cohort, so a study of about 80,000 farmers, their spouses, and commercial pesticide applicators. And so this study followed this cohort looking at their deaths between 1993 and 2009 using record linkage. And so they used estimates of PM 2.5 derived from remote sensing. And so you can see the exposure surfaces in these two maps at the bottom in North Carolina and Iowa, where the cohort members lived. And so unlike the sparse monitoring from ground-based monitoring locations that was really the only source of data in the past, these exposure surfaces provided comprehensive exposure estimates over the entire state. And in this study, significant associations were observed between PM 2.5 and cardiovascular mortality risk in certain subgroups of the population. So that study was looking at effects of long-term exposure, but these new exposure methods have also been used to look at effects of short-term exposure. So this is a time series study of cardiovascular and respiratory hospitalization. It just actually appeared in the latest issue of Environmental Health Perspectives. So they looked at 28 million Medicare beneficiaries in both urban and non-urban counties. And so they highlighted that by including non-urban counties, this was an understudied population for reasons that I've described already. And so in this case, they used a, excuse me, air quality model to estimate daily exposures. And it was interesting that they found the largest association between PM 2.5 and respiratory hospital admissions occurred in the more urban counties. So that's the area highlighted in red here. And the largest effect on cardiovascular hospital admissions was observed in the more urban counties, so the area highlighted in blue. And they hypothesized that possible explanations for this were differences in the population between more rural and urban counties, possibly differences in composition of PM in rural and urban counties, or differences in exposure measurement error between these different areas. Now, we also did a national study of PM 2.5 and pregnancy outcomes across Canada. So looking at about 3 million births, about 500,000 in rural areas over a 10-year period from 99 to 2008. And we used exposures to PM 2.5 that were based on a national land use regression model. And this incorporated measurements from both fixed site monitoring and satellite observations. And so we actually found similar effects in urban and rural populations. So on the left, effects on birth weight ranged from decrements of 15 to 20 grams in weight per 10 micrograms per meter cubed in urban and rural populations. And on the, excuse me, on the right, odds ratios of 1.02 to 1.05 in urban and rural areas. And in neither case was the difference between urban and rural areas statistically significant. I also wanted to talk about a couple of panel or intervention studies that have been done in rural areas. So this one by Ryan Allen in Smithers, BC. So an actual intervention study related to wood smoke. So this was a randomized crossover intervention study where individuals were exposed to either filtered or non-filtered air for 7-day periods. And they found that air filters reduced indoor fine PM by about 60%. And this was associated with about a 9% increase in reactive hyperemia index. So this is a measure of endothelial or cardiovascular function. And then about a 30% decrease in C-reactive protein, which is an inflammatory marker. And then we did a similar study in the Annapolis Valley in Nova Scotia, minus the health measures. So it was a similar randomized crossover study, and we found a similar about 50% reduction in indoor PM 2.5 with air cleaners, and then also a reduction in PM infiltration, and that's what's shown in the plot on the right. So infiltration factor being the ratio of indoor to outdoor concentrations after indoor peaks related to indoor sources are excluded. All right, so then I wanted to finish off talking about a panel study that we did in southern Ontario. So the main objective for doing this study was to determine whether the Air Quality Health Index, or AQHI, actually works in rural areas in terms of being a predictor of health risk. So the study was conducted in Kincardine, Ontario. So it's shown with the red marker here. It's about 200 kilometers northwest of Toronto. It's located on the shore of Lake Huron. And so if you remember from the figure that I showed earlier of the coal-fired power plants in the US, Kincardine is kind of on the receiving end of long-range transport from those areas. And so because of the lake, there's no opportunity for scavenging of ozone by NO. And so we looked at non-smoking adults 55 and over 2 summers in Kincardine. And what we did was have the participants monitor on a daily basis their blood pressure, finger oximetry, and peak flow. And this was before and after 30 minutes of light exercise, so walking or equivalent activity. And this was over a 10-week period. And then on a weekly basis, we also measured heart rate variability. So this is done using a Holter monitor, and heart rate variability is basically a measure of the ability of the heart to respond to stress. We also measured reactive hyperemia index, which is the measure I mentioned in the study in Smithers. And so this is a measure of endothelial or cardiovascular function. We also measured fraction of exhaled NO in breath, and that's a measure of respiratory inflammation, spirometry, and then 4 oxidative stress markers in urine. So malondialdehyde, 8 isoprostane, 8 hydroxydeoxyguanosine, and vascular endothelial growth factor. So in terms of the exposure conditions during the study, CO, NO2, and SO2 concentrations were low, as would be expected in a rural area. And ozone and PM 2.5 concentrations were moderate. So mean concentrations of ozone were in the 40s and of PM 2.5 in the low to mid-teens, and maximum concentrations of ozone in the 80s and 90s, and PM 2.5 in the 40s and 50s. And then you can also see here that the Air Quality Health Index, which is generally on a 0 to 10 point scale, was around 6, the maximum value in both summers. So in terms of the statistical analysis, we used linear mixed effects models. And so dependent variables, so the health measures were log transformed if needed, if the distribution was skewed. Subjects were treated as random effects, so this means that each subject was basically acting as its own control over the course of the study using the repeated measurements. Air pollution personal characteristics were treated as fixed effects, and we used a non-linear function of temperature to adjust for effects of temperature. There's also an autoregressive term to control for serial correlation between observations. And we looked at air pollution and temperature lagged 0 to 2 days. So the effect of air pollution on health measures the same day and then the following 2 days. And then the analysis was conducted by year, and then the results pooled across the 2 summers. So these are our main findings, and I recognize this is kind of a busy slide, but I'll walk you through it. So what it's showing on the vertical axis is the percent change per interquartile range of each pollutant. And so the health outcomes that are shown here are those where we observed the most consistent association. So we have heart rate, and then 4 heart rate variability measures: high frequency power, low frequency power, root mean square of successive differences, and a standard deviation of normal to normal intervals. So these are measures of beat to beat variability in heart rate, fraction of exhaled NO, and then reactive hyperemia index. So what this shows is the percent change by pollutant and by year, and then the third measure in each series is the pooled result across the 2 summers. And I'll mention that the data for heart rate were untransformed while the other measures were log transformed, so that probably accounts for some of the difference in magnitude of association that you see here. So basically what we saw is associations between PM 2.5 ozone and the AQHI with an increase in heart rate, a decrease in some of the heart rate variability measures. And in these instances, it seemed that the effects were larger in 2013 compared to 2014, both for heart rate and the heart rate variability measures. We also saw increases in fraction of exhaled NO, so again, a marker of respiratory inflammation. And probably the most consistent results between the summers were decreases in reactive hyperemia index. So this is a decrease in endothelial function. Now, in terms of the possible explanations for the more consistent effects in 2013, we hypothesized that although the air quality and temperature conditions were similar for the 2 summers, there's a lot more rain in 2014, so people may have spent less time outdoors in general, even though they were doing their outdoor activity for the study. And so this may have resulted in reduced overall exposure to outdoor air pollution in 2014. And I should mention that we applied the same study protocol in a study in Prince George in 2 winters in 2014 and 2015. We haven't finished analyzing the data yet, but we are seeing some similar associations there. Now, one other interesting finding was that we found in 2013 some evidence of greater effects in non-statin users. So statins are a cholesterol-lowering drug, which is thought to have also anti-inflammatory properties. And so you can see here that we saw decrements in heart rate variability. These are in non-statin users, whereas in statin users, effects were either positive or null. And this has been observed in some other studies that statins modify the effects of air pollution on cardiovascular measures. Now, I also wanted to talk about a sort of incidental finding. We included day of study as a covariate in our models to account for the effect of trend. And we found fairly consistently, as shown here, that over the course of the study there was a reduction in heart rate, an increase in some of the heart rate variability measures, and in the reactive hyperemia index. And so these would be considered cardiovascular benefits of exercise, basically. And this is consistent with what's been observed in clinical trials and observational studies. We also saw an increase in fraction of exhaled NO, which would be considered basically an adverse effect of the outdoor activity over the duration of the study. And these effects were actually more consistent between the two summers than the associations that we saw with air pollution. Now, I should caution that this study was designed as a repeated measure study to look at adverse effects of air pollution. As I mentioned, each subject served as its own control based on the repeated measures that were done over the course of the study. It wasn't designed to look at the benefits of exercise. There was no control group that didn't exercise. But in any case, it may not be particularly surprising based on the literature what we know about benefits of physical activity that we might have seen this, but it was still a little bit unexpected that we saw this so consistently. So it just goes to show that research is kind of like a box of chocolates. You just never know what you're going to get. Actually, I'm not done yet, so appreciate the applause anyway. I was just going to wrap up with a few key points here. First of all, although the percent of the Canadian population that lives in rural areas has been declining, there's still a sizable rural population. And this population does have an increased prevalence of certain factors that make them more susceptible to air pollution. So in particular, elderly age groups, chronic cardiovascular and respiratory disease, and outdoor work. I mentioned a few of the exposure science innovations that have improved our ability to characterize air pollution exposure in rural areas. And these have also allowed us to include rural populations in large health studies where previously they would have been excluded. Some of the key exposures that are important in rural areas, photochemical smog and wildfire smoke in the summer, and wood smoke in the winter. And then I also mentioned some of the results that we found in terms of the overlap between exposure to PM 2.5 and ozone and areas which also have a high percent of the population that's susceptible, particularly susceptible to adverse effects of air pollution. And so these may indicate that there are unmet risk communication and management needs if these populations are actually unaware of either their susceptibility or their exposure. So I'm done now. You can applaud again. So I'm happy to take any questions if there are any.
We're now opening the floor to any questions. So
So thanks a lot, Dave. Have to remember your trick about how to get more applause.
Yeah, right.
Throw in a couple slides. So really interesting about the susceptibility factors. I guess there are also perhaps other things that may counteract that. So physical activity,
Right.
maybe, I guess, higher, and you had, I guess, being outdoors doesn't necessarily mean you're physically active, but you did show that stat with more.
Right.
And then also absence of other co-exposures, so things like noise.
Right.
So I just wondered if you have any thoughts about, actually, does susceptibility matter, or is it something else?
Right. Yeah, that's a good point. And I'm not sure offhand of the evidence on percent of sort of leisure time physical activity in say rural compared to urban areas. I don't know if anybody else is familiar with that data. We obviously found evidence of the amount of time that people spend outdoors in rural areas, and some of that probably is related to outdoor work, and some of that is obviously more strenuous. So whether that strenuous work is necessarily a good thing from a cardiovascular point of view, I'm not sure offhand. I don't know if others have looked at that. I think one of the other issues maybe to highlight, and a colleague pointed this out in looking at some of our initial findings, was that our analysis was really looking at both susceptibility and exposure on a larger regional scale, but you'd expect also to see variability in both susceptibility exposure and exposure at a much smaller scale, especially in urban areas. This is one of the things that's been highlighted in kind of the environmental justice research, that some populations in kind of dense urban areas have both sort of socioeconomic stressors, higher prevalence of those, as well as higher exposure to sort of traffic pollutants in urban areas. So I'm not sure that really answered your question exactly, but some other factors that I think are important to consider.
Any online questions?
Online question here, and it is wondering what the difference is between short-term accumulated and chronic.
Short-term accumulated and chronic?
Yes.
I think in terms of exposure, short-term exposure would generally be considered, in terms of hours to days, maybe weeks in some circumstances, and long-term would be generally over the course of years. Cumulative exposure, I think would generally fall into the same sort of category as chronic, but it may depend on the context in terms of the particular, exposure agents that you're looking at.
And I will put in a plug for another exposure of interest in more rural communities, which is especially true in BC, which is road dust.
Yeah, good point.
Thanks, Dave. Great talk. Question about some of the graphs. One that you showed from a StatsCan measure, that proportion of population in rural is higher in certain Atlantic provinces.
Right.
And you also say that some of the policy changes coming from our southern neighbor may precipitate a worsening of conditions for folks over there. And I'm not sure if there are AQHI monitors in some of the rural areas over in Atlantic provinces, in those areas. But nevertheless, my question is, would there be special targeted risk communication messages to public health professionals over there to protect the health of the rural population differentially more than other parts in the sub-rural urban centers, for example?
Yeah, I think that's a good point, and that speaks to the point I was trying to make about maybe unmet risk communication needs. I know we did some survey work. This was a long time ago, and I'm not sure that it would still be accurate, looking at sort of awareness of outdoor air pollution as a risk in rural compared to urban areas, and maybe not surprisingly, the level of awareness was lower in rural areas. And obviously, I think in some cases people base their understanding on their own perception, and air quality would probably generally be perceived as being better in rural areas, and it is in terms of some pollutants like vehicle-related pollutants. But yeah, I think from a risk communication point of view, it's a matter of sort of maybe correcting some of those misperceptions and making sure that people in rural areas understand, both from a personal susceptibility point of view and also an exposure point of view, that there may be things that they should be aware of that they might not have been previously. And like you pointed out, we've always had certain issues with long-range transport of air pollution from the U.S. and it could certainly be the case if there's ramping up of coal production and use in the U.S. that could get worse. And I know there are certain rural areas that do, like the area where we conducted our study in southern Ontario, Kincardine. There's a nearby Ministry of Environment monitor that reports the AQHI, and I believe there are in the maritime provinces in certain areas as well. But yeah, the density of monitoring is going to be a lot less in rural areas.
Well, unless there are any further questions. Are there further questions?
Yeah, there's one online.
Hold that thought then.
I'll forget that if it's long.
But it's really hard to read when they're long because I have a very narrow window. Okay. In our area, the Columbia Valley of BC, the regional health statistics show much higher incidence of heart and lung disease than in Vancouver, but also higher rates of smoking. Health officials tell us that we cannot then determine the influence of ambient air quality on health. We have very high measured levels of PM 2.5 in Golden. How can we address this issue as a lack of precautionary principle in addressing air pollution?
Okay, yeah, I mean, I think if I understand correctly, cardiovascular disease is certainly multifactorial, and cigarette smoking and other factors obviously play a role, just like air pollution does. I mean, generally, I guess the contribution of some personal behaviors like smoking is much larger than that of factors like air pollution in terms of contribution to incidence of cardiovascular disease. But generally, I think from a public health point of view, we try to take a multifactorial approach. Just because one risk factor is present, that doesn't mean that other risk factors don't also need to be addressed. So I'm not sure if that totally answers the question. But,
Thanks. I'll squeeze in another question. Thanks for your earlier answers, Dave. Suddenly, I thought about radon and the one of the health effects from air pollution.
I don't know anything about radon.
No, well, I'm looking. I call up the radon potential map of Canada and
Right.
notice that high zone areas in Atlantic provinces and also southern Ontario too. So the multiplicative effect of air pollutants on cardiovascular system, the respiratory system, all that could be exacerbated by concomitant exposure to radon. I'm just saying that there could be a great opportunity to do targeted risk communication, maybe working with the lung associations to do the health promotion necessary, especially for certain vulnerable populations.
Yeah, I mean, I think the one thing maybe that I do know about radon is the combination of smoking and radon, and I do know that the prevalence of smoking does tend to be higher in rural areas. So, to the extent that those areas correspond to high radon exposures, I think that makes a lot of sense. That there's a health promotion opportunity there.
Okay. Do you have any thoughts regarding the cardiorespiratory AQHI study in older adults 55 plus? Do you think you would see similar findings in younger individuals given the cardiovascular changes that we would see as someone ages and thus could put older individuals at more risk?
Yeah, I mean, one of the reasons that we chose older individuals as the study population was just basically to maximize the signal from an epidemiology point of view. We were putting a lot of time and effort into this and wanted to be able to detect a signal if there was one. So I think it would be less likely to see some of the associations that we saw for the specific measures. Now, one younger population, though, that I did highlight in one of the earlier studies was asthmatic children. Again, that's a more sensitive population where you would expect to see a bigger signal. But yeah, I think it might be difficult to see cardiovascular effects in younger populations.
Well, I think that's all the time we have for today. So thanks again for your excellent talk and for concluding our term's OEH seminars. I look forward to the next batch of seminars starting next September.
Thanks very much.
Please join me in welcoming David once more for his excellent talk.